Previously, we learned about mini-Trias disease, which is a hypertrophic gastropathy. Now we are going to learn about Zollinger-Ellison syndrome, which is also a hypertrophic gastropathy. See, be it mini-Trias disease or Zollinger-Ellison syndrome, at the end of the day, what are they? They are hypertrophic gastropathologies. So if you know what hypertrophic gastropathy is and how it occurs and what it results in, studying mini-Trias disease and Zollinger-Ellison syndrome becomes much simpler, because after that you are done with 90% of the concept. That's the reason why under mini-Trias disease I have spent majority of the time explaining about hypertrophic gastropathy, but since I know that you are quite ulsi prani, I'm going to repeat it once again, but in much shorter. This is going to be a shorter version of the previous explanation. Okay, hypertrophic gastropathy. It is a pathology of stomach. What kind of pathology? Hypertrophic pathology, because there is increment in size of the stomach, enlargement of the stomach. And the reason behind the enlargement of the stomach is epithelial hyperplasia. Okay, small concept. This is a gland which is lined by glandular epithelium. Okay. Let's say this gland goes through glandular hyperplasia. As a result, there is increment in the number of cells in the glandular epithelium. Now, in order to accommodate this increased number of cells, what should the gland do? It must somehow increase its surface area, so that if there is more area within the same gland, more cells can accommodate, and it does so by bringing about a papillary infoldings. Now there is increment in the surface area, so the increased number of cells can easily accommodate within the same gland. Okay, now let's talk about stomach. This is your stomach. The stomach, the wall of the stomach, the inner wall of the stomach, it contains something called gastrirugi, which are your rugal foldings. It increases surface area as well for the glandular epithelium. But let's say there is increment in the number of cells in the glandular epithelium, in the lining epithelium of the stomach. Then what will happen? Then these rugal foldings will get exaggerated, highly folded. Why? In order to increase surface area, in order to accommodate the increased number of cells. Previously, while talking about gland, we are talking about microscopy, how it brought about papillary infolding to accommodate the increased number of cells. While talking about stomach, we are talking about gross or macroscopy. There is already rugal folding, but this rugal folding becomes even more exaggerated. It is even more prominent. Why? Because there is increment in the number of cells lining the inner wall of the stomach. The increment in the number of cells of epithelial mucosa. That is why the rugal folding becomes more exaggerated to accommodate that increased number of cells. All right, this concept is clear. Okay, now listen to this story. We have an epithelial cell lining the wall of the stomach within the epithelial mucosa of stomach. This epithelial cell goes through the process of mitosis and then divides into two. Good. For mitosis to occur, the cell needs to be triggered either by a growth factor or some kind of hormone. Some kind of hormone or growth factor triggers this cell, mitosis occurs, and then it divides. Let's say there is abnormal increment in this growth factor or abnormal increment in the hormone. That will trigger mitosis. As a result, there is abnormal increment in mitosis, resulting in abnormal increment in the number of cells. The cell divides, right? The division of the cell is controlled by hormone and growth factor, right? If hormone and growth factor more, cell division more. If cell division more cells. Okay. This is called hyperplasia. Which cell is going through hyperplasia? Epithelial cell. So what kind of hyperplasia it is? It is epithelial hyperplasia. Okay, that part also done. Now listen to me. There is epithelial hyperplasia due to increased release of growth factor or maybe certain kind of hormone. So there is increased release of growth factor or certain kind of hormone, resulting in increased number of epithelial cell As a result, there is epithelial hyperplasia. There is more cells within the stomach, more cells within the stomach. Now, in order to accommodate these increased number of cells within the stomach, what happens? Already I said the rugal folding gets exaggerated, too much rugal folding. And what you get? You get hypertrophic gastropathy. Means there is increase in the size of the stomach due to epithelial hyperplasia with exaggerated rugal folding. And the reason behind epithelial hyperplasia is either due to increased release of growth factor or certain hormone. Now, let's say I have this stomach right here. This stomach has that exaggerated rugal folding, or this stomach has gone through hypertrophic gastropathy, right? It has increased in size and it has lots of rugal folding. What I do is that I make an incision along the greater curvature. Okay, then I open this stomach like a book. I open this stomach like a book. This is what I'm gonna get. This is the antrum of the stomach, and you can see that the antrum is flat. So antrum of the stomach is spared. There is no exaggerated rugal folding in the antrum of the stomach in hypertrophic gastropathy. The antrum of the stomach is spared. But look at the fundus of the stomach. Look at the body of the stomach. The fundus and the body shows that exaggerated rugal folding. So much rugal folding. See, the rugal folding is so highly exaggerated. As a result, it looks like what? It looks like your cerebrum. And that is why it's called cerebrum appearance of the stomach. And since due to this rugal folding and due to increased number of cells, the stomach has increased in size, it is called cerebriform enlargement of stomach. That's why hypertrophic gastropathy, pathology of stomach that results in increased size of the stomach. All right. Under hypertrophic gastropathy, we have many diseases, but among those, the important ones are Many-Triers disease and Zollinger-Ellison syndrome. Now, what distinguishes between the two are two things. Number one, increase of what leads to epithelial hyperplasia. Okay. Number two, what type of epithelial cell within epithelial mucosa of stomach shows hyperplasia. Two things. Number one, increase of what results in hyperplasia, and number two, what goes through hyperplasia. Under Many-Triers disease, we have already learned that there is increase in transforming growth factor alpha, TGF alpha, which results in increment or hyperplasia of which cell? The foveolar cell lining the wall of the stomach, TGF alpha and foveolar cell. But now, Zollinger-Ellison syndrome. In Zollinger-Ellison syndrome, this is the story. So, within the lining mucosa of the stomach, within the epithelial mucosa of stomach, you have parietal cell, right? Parietal cell is responsible for secretion of hydrochloric acid. On the surface of the parietal cell, there's a G protein coupled receptor. This receptor is for gastrin hormone. What? Gastrin hormone. And this particular G protein coupled receptor for gastrin hormone is cholecystokinin B receptor. So gastrin hormone, it binds with cholecystokinin B or G protein coupled receptor and triggers the release of HCl from parietal cell as well as division of parietal cell. Two things, okay? So gastrin, which is a local hormone, gastrin, a hormone, it binds with G protein coupled receptor present on the surface of the parietal cell and triggers the parietal cell to go through two things. Number one, secrete HCl, and number two, divide. Now let's say there is somehow an abnormal increment in gastrin. Then what happens? There is abnormal triggering of this G protein coupled receptor, increased stimulation of G protein coupled receptor. That means the end result is also going to increase. There is going to be increased release of HCl from the parietal cell as well as increased number of parietal cell due to increased division, and this is parietal cell hyperplasia. So once more, in Many-Triers disease, there was increment in TGF alpha, which resulted in foveolar cell hyperplasia. In Zollinger-Ellison syndrome, there is abnormal increment in gastrin hormone that results in parietal cell hyperplasia. Okay. Now, second thing, how is it that there is an abnormal increment in gastrin hormone? that takes place due to a tumor, which is gastrinoma. I mean, the name says it all. Gastrinoma, it's a gastrin secreting tumor. What type? Neuroendocrine tumor. So gastrinoma is a gastrin secreting neuroendocrine tumor. See, at the end of the name, there is oma. However, it is a misnomer. That is, gastrinoma is not necessarily benign. 60 to 90% of gastrinoma, they are actually malignant. If you see gastrinoma, it is most likely gonna be malignant. So simply, gastrinoma is malignant. However, at the end, there is oma. So it's a misnomer. All right. Second thing, where are you gonna see this gastrinoma? Where is this tumor gonna be? Location of the tumor. And that is given by something called gastrinoma triangle. Gastrinoma triangle will tell you which are the most common locations for development of gastrinoma. And they are, number 1, the junction between cystic duct and the common bile duct. Number 2, the junction between head of the pancreas and the neck of the pancreas. And number 3, the junction between the second part of the duodenum and the third part of the duodenum. Again, what are they? The junction between the cystic duct and the common bile duct, the junction between the head of the pancreas and the neck of the pancreas, and third, the junction between the second part of the duodenum and the third part of the duodenum. If you can't remember this much, at least remember gastrinoma mostly develops in duodenum and pancreas. I hope you can remember that, right? Okay. Now, more about the tumor gastrinoma. Let's say there are 100% of the gastrinoma cases are presented to you. 100% of the gastrinoma cases are presented to you. Out of 100% of the cases, 75% of them are going to be sporadic and single. The remaining 25% is most probably going to be familial, that is associated with genetic mutation, and the genetic mutation is MEN1 mutation. Multiple endocrine neoplasia 1 mutation, right? Multiple endocrine neoplasia 1 mutation, quite easy to remember. See, MEN1 mutation resulting in familial gastrinoma will result in multiple tumors, right? See, 100% of the cases, 75% is S for sporadic, S for single, and 25% of the cases is due to M for MEN1 mutation and M for multiple. MEN, full form MEN, multiple, E for endocrine, and for neoplasia, 1 mutation. Are there multiple tumors? Yes. So multiple. Is it an endocrine tumor? Yes, it is an endocrine tumor. So endocrine. Is it a tumor? So neoplasia. So multiple endocrine neoplasia 1 mutation. All right. What are the clinical features? See, first, it's peptic ulcer disease, and nothing to be shocked about. I mean, there is an increment in HCl secretion. There's too much HCl in the stomach. It will result in ulcer eventually. And most commonly, it's duodenal ulcer. Remember that duodenal ulcer, Zollinger-Ellison syndrome, is associated with duodenal ulcer. See, let's say a patient has peptic ulcer disease, right? And then you took the history of the patient. There is no chronic use of NSAIDs, number 1. Then you performed lab diagnosis of the patient, and Helicobacter pylori infection was not seen. So probable cause could be Zollinger-Ellison syndrome. Okay. Second is diarrhea. How diarrhea? There's too much acid within the stomach. This too much acid within the stomach is going to enter the duodenum. Inside the duodenum, alkaline medium is required for the digestion of fat. But since there is too much acid in the stomach, and this too much acid in the stomach enters the duodenum, that alkaline medium is not maintained. That means fat digestion will not take place, and undigested fat is pooped out, leading to diarrhea. And fat specific diarrhea is called steatorrhea. So there is steatorrhea as well. All right, done. That's Zollinger-Ellison syndrome. One last revision. So what was the cause behind hyperplasia? Increment in which hormone? Gastrin hormone, which led to hyperplasia of which epithelial cell lining the wall of the stomach? Parietal cell. As a result, there was increased HCl secretion, which led to clinical features like peptic ulcer disease and diarrhea. The reason behind abnormally increased amount of gastrin was the tumor gastrinoma, which is a gastrin secreting neuroendocrine tumor. Even though it has oma at the end, is it benign or malignant? 90% of the time it is malignant. The most common areas where gastrinoma develop is given by the gastrinoma triangle, which is composed of the junction between cystic duct and the common bile duct, the junction between the head of the pancreas and the neck of the pancreas, and the junction between the second part of the duodenum and the third part of the duodenum. Out of 100% of the cases of gastrinoma, 75% are as for sporadic and as for single, while 25% of the cases are familial, that is due to MEN1 mutation, M4 MEN1 mutation, and M4 multiple. And with that, we are done with hypertrophic gastropathy, both Many-Triers disease and Zollinger-Ellison syndrome.